Good morning, and I'm happy to be here. So it was amazing for previous speakers, so I can see a little bit the future. But what I'm saying generally that the most of those patients will need our help. I'm for 30 years in rehabilitation. 10 years ago, I didn't see those patients in my department. They were not alive. Now you are keeping them alive, but for today's patient, it's not enough to be alive. He wants also to have a good life on good quality, and here the rehabilitation comes into the future. I'm trying to, yes, it's okay. So I will say a few words about the rehabilitation, the main points of principles of rehabilitation, where also, as our geriatric friends are speaking about patient-centeredness, we cannot deal with the problem, with the medical problem. We are dealing with the patient. Patient is in the center. For me, two patients after stroke with the same stroke, but one of them she is living on third floor without elevator, and the second one with elevator. It's a different program. So we are speaking about patient, and we are treating the patient. We are speaking about the very early stage of rehabilitation, and if many years ago we took patients to rehabilitation department 30 days after stroke, now we are taking them few days after stroke, and we are starting an intensive rehabilitation care. And in the same time, we want also to be in the acute departments and to start from the very beginning, because every day patient is lying in the bed, even he needs it. It's not good for him. It's a lot of complications, and we need to activate them and to start the program. We're speaking a lot about care which start very early, and in some cases never stop. So in severe patients, we need the rehabilitation therapy till the end of their life. So when I'm speaking about Israel, and I know all over the most world, we are quite strong in the middle stage. We are quite strong to taking the patient and to putting him back walking, but we are very weak in the first stage, and we are very weak in the last stage to go on with the rehabilitation when they are already home. So I think the future, it's not for us. It's not only the technology, it's maybe also the technology, but also the many changes in the care system and in the ability of our system to take care of those patients early and late. We are dealing with the whole program. Many professionals are included. It's not easy, and we need those professionals also. Let's say in the south, we cannot find speech therapists because there is not enough speech therapists in some regions. I also know in the world, not only in Israel. We're speaking about ICF as a program, so I will not go into this issue, but for us it's very important to treat once more not the patient, but not the problem, but the patient and the family and the all around him. The biggest problem of all of us, as I told, that there is a very rapid growth in rehabilitation demand. It's very rapidly. We can see here one of the publications from the situation in the world, and on the other side of the slide, we can see what happened in the south of Israel. We came to the Israel we opened in Soroka the first rehabilitation department in the south, and we have now 7 years when we are there. For 7 years, we have tripled the amount of patients, almost tripled, as you can see, the amount of patients who need rehabilitation. Of course, that's issue of knowledge, and that's issue of ability to have the rehabilitation care. So in today's situation, with the better treatment and the older population, we will see the go-on growth around the world, and we must be ready to manage it somehow. When we are speaking about technology, this Congress is about technology, so it's important for rehabilitation technology. Generally, we can speak about two fields. First is technological innovations for improved regeneration of tissue. There are a lot of them. I cannot say that we have a huge successes, but I think it's very important to go on. So in other words, we can take the paralyzed patient and to make him not paralyzed, in simple words. The second is a compensatory technology, when we are saying okay, patient is paralyzed, but we can help him to do everything in his life, to walk, to go back to his job, and so on. And in this field, we have a lot of technologies, and they are improving. They will be better, and generally, we are very happy about that. The examples of the first group is it's a lot of research about that today. It's transcranial stimulation, different kinds of stimulation, stem cell therapy, and some other techniques. We can see here, I have not time to speak about all of them, but there are a lot. In Modern Rehabilitation Center, also in Soroka, we can see many of them, but we are moving forward. I came back for a very short time because we are in the annual Rehabilitation Congress in the other place of Israel, so we are hearing about the more and more technological intervention to bring patient back to his previous ability before the disease or before the injury. The second group, as I told, is a compensatory technology. I think we are much better in this field, and there are a lot of them. In some cases, it's a mixed. We can bring the patient to make things better as a compensation, but in the other, from the other point of view, this activity will push forward the plasticity of the brain, as an example, or other kinds of plasticity, and we will see the improvement of his basic ability. So I would say that it's both dimensions and both types of technological interventions. So that's also the examples of those kinds, and once more it's moving forward and it's making better and better. It's my last slide. So what are the things that we as a rehabilitologist think that it's important to do? The technologies must be simplified. It's very important. In most cases, I would like to give the technology for the patient to his home, to go on to use it. But it's very expensive, it's very sophisticated, and most of patients cannot have them for themselves. So the whole things of rehabilitation timeline must be improved, as I told, from the especially for the beginning and for the after rehabilitation setting time. The third thing is we need more rehabilitation specialists, not only doctors, but also doctors. You spoke about 500 geriatricians. We are about 100 in the whole country. So, but in today's Congress, we are 600 people. 500 of them are not doctors, are rehabilitation specialists from other specialties, physiotherapists, occupational therapists, and so on. So all those specialists, we need more, and we need to work on that. And the last one, we need to change the regulations and to make the technology cheaper, to bring it to all our patients, even to those who live on the third floor in Beersheba without elevator. So thank you very much.